Thank you everyone for joining us. Welcome to the latest Duke media briefing on the COVID-19 pandemic and its effects on society. I'm Gregory Phillips with Duke Communications. The CDC currently recommends masks be worn in K-12 schools, but a proposed state law in North Carolina would make school mask mandates a matter for county boards of education to review monthly. We have two Duke pediatricians with us today, both leaders in the ABC Science Collaborative, which at the state of North Carolina's request has been gathering data on in-school transmission of COVID-19 over the past several months. Their findings are part of a new report that offers a blueprint school districts can use as part of their planning to provide safe instruction for the coming year. With us today is Dr. Danny Benjamin. He is a professor of pediatrics in the Duke School of Medicine and chair of the National Institute of Child Health and Human Development's Pediatric Trials Network. Good morning.
Good morning.
Also joining us is Dr. Kanecia Zimmerman. She is an associate professor of pediatrics in the Division of Critical Care Medicine at Duke University Medical Center. Good morning to you, Dr. Zimmerman.
Good morning.
And Dr. Benjamin, we'll start with you. Can you just lead us off with telling us what were the main findings of your research?
Sure. So first and foremost, North Carolina school districts, K-12 education, and the charter schools did an outstanding job of preventing COVID-19 transmission within schools. Remember that as long as there's COVID in the community, children and adults will bring infections into the schools. The key deliverable for schools is to prevent transmission from human to human within the school environment. And the LEAs, the school districts, the public schools, the charter schools, they have done a resoundingly effective job in Plan A at preventing that transmission. There are 100 school districts that went into Plan A. That means no distancing required, full-time face-to-face instruction for children in K-12. And that represents over 1 million children and adults in full-time face-to-face instruction. And local health departments and school districts determined within school transmission rates and across the entire state of North Carolina for the last 10 to 12 weeks of school, there were only 308 such transmissions between children and fewer than 400 across children and adults across the 10 to 12 weeks that school districts were sending data to us in real time. This is an extremely low rate of transmission. It's less than 1% secondary attack rate that we've estimated based on the number of children and adults that were placed into quarantine as a result of exposure to COVID at schools. So with masking, the schools clearly can safely deliver face-to-face education for children and adults. They can have 1, 2, or 3 children ride on the school buses. We collected that data from the school districts. The amount of distancing, whether it's less than 6 feet, less than 3 feet, or no distancing at all, that didn't make any difference. The amount of distancing did not make any difference, provided that there was masking in place. The nice thing is for schools and the state is that these districts did not do, by and large, overhauls to their ventilation system. Some schools did change some filters and do some changes to their ventilation system, but we didn't see widespread changes to ventilation. We didn't see widespread changes to approaches and testing. So it's very simple tools for us for next year that are available if folks choose to do that, which is vaccination and masks. And this means that we don't have to close schools again. We don't have to have remote instruction. We've got tools that will keep the children and adults safe in school.
Absolutely. Thank you for that. Dr. Zimmerman, to come to you, Dr. Benjamin just mentioned that distancing need not be a component of this. Can you talk a little bit more about your findings regarding distancing?
Great. Just as Danny said, we studied districts that had 6 feet of distancing between students, 3 to 6 feet of distancing between students, and then less than 3 feet of distancing between students, and even on buses where there were 1, 2, or 3 children to a bus seat. And again, there were no differences between those 3 distinctions in distance as to their secondary transmission rate. So this suggests that we can have full in-person instruction with masking in place.
Absolutely, thank you. And Dr. Benjamin, can you tell us a little bit more? You've mentioned how many school districts were involved in this, but talk a little bit more about the methodology and what the evidential basis is for your findings.
Sure. So the state legislature, Governor Cooper, DHHS, DPI, and the state school board came together with bipartisan legislation that was very forward-thinking. It really placed North Carolina, of the 50 states in the country, as foremost among the 50 states as far as optimal response is concerned. That is, they got children back to school face-to-face full-time for all elementary school children, and the option of Plan B, which is 6 feet of distancing, or Plan A, no distancing, full-time face-to-face instruction. As a part of that, the state mandated that the school districts report every week their community-acquired infections and their secondary or within school transmissions. And the school districts entered that data in anonymized data so that there was no way for any researcher to identify any people involved. And they did that in collaboration with their health departments to determine who was infected in the community versus who was infected in school. And they showed conclusively that they were able to prevent infection at school, to prevent transmission at school.
Absolutely, thank you. Dr. Zimmerman, as part of this report, your team has generated a path forward. Can you talk about what some of the details are of that blueprint?
Sure. We, as the ABC Science Collaborative, we are made up of scientists from North Carolina and from 13 other states across the country. We developed a document that was based on available science, including some of the data here from North Carolina. That document underwent review by multiple scientists or pediatric scientists across the country as well. And it really talks about the available science with regard to masking, with regard to distancing, with regard to hand hygiene, and things like deep cleaning. The data from North Carolina definitely add to the data coming from places like Utah, Wisconsin, Missouri, Mississippi. All of it says the same thing, that with masking in place, the secondary attack rate is really, really low. There's a couple of key messages that come out of that. One, we can be successful, as Danny mentioned. We don't need to go back to remote education. We have tools in our toolbox in order to move forward. But two, what we've seen is because of masking, because the secondary transmission rate has been extremely low, in the mask on mask environment, kids who are coming in contact with a positive person are having to quarantine for a substantial period of time. That means collectively in North Carolina, we had more than 40,000 people who had to quarantine during the 10 to 12 weeks. More than 40,000 people is hundreds of thousands of school days that have been missed because of quarantine. And yet the benefit that we're seeing is nil. It is very minimal transmission. Therefore, the risk to go to enhance community spread really is not there. So we have this missed school days without the benefit of actually controlling spread. This is something that I think we should think very carefully about as we move forward. And I think the data has been very strong in places like Missouri and Utah in particular, where the secondary transmission rate is very low and they have these modifying quarantines where people in the mask and mask environment are able to stay within the classroom.
Sure, absolutely. Thank you. And thanks you both for that comprehensive introduction. We're going to open it up to questions. Thanks to everyone who submitted questions in advance, and we'll start with those. But you can also pose questions via the Q&A window at any time. And thanks also to everybody watching on YouTube. Okay, so first of all, Dr. Zimmerman, I'll come back to you. We've had some questions about this. Can you tell us what your findings were regarding athletics and the risk of transmission there?
Sure. I think our findings, in addition to the findings across the country, suggest that athletics, particularly indoor athletics, can be a higher risk environment than the outdoor space and then the classroom. That means that we need to have specific policies in place in order to protect athletes. Vaccination is extremely effective, as well as masking. There are places in Missouri that have been very successful in masking during athletics and implementing masking and enforcing masking during athletics and reducing transmission. So suffice it to say, even in this high-risk environment, we can be successful with these tools in place.
Absolutely. Thank you very much. We also have a question that came in advance from MedPage. Dr. Benjamin, I'll direct this to you. So do you expect some anxiety among children returning to in-person instruction? And what kind of role can parents play in allaying those concerns?
Sure. So some of the children are going to be anxious, and we've already seen that throughout the country. And the way that we approach that kind of anxiety at our house, and we have 4 children, is if the adults will treat this as an adventure, and if the adults will treat this as something that is fun and an opportunity, the children tend to respond better to that. For the older children, of course, the opportunity to be vaccinated right now really does provide a safe environment, regardless of where the children might be. For the younger children, that's a more nuanced discussion around, what they're going to be seeing at school. But we know from the past 10 to 12 weeks that North Carolina is fully capable of preventing transmission at school.
Sure, absolutely. Thank you very much. And we've already had several questions come in, and that's great. So please do keep them coming. Dr. Zimmerman, I'd like to come back to you. You touched upon this a little bit in talking about the path forward, but obviously you studied North Carolina. Can you put this in a bit more of a national context? And do you feel like those findings hold for nationwide?
Absolutely. So there are data from Missouri, there are data from Utah where people have had 3 feet or no feet of distancing between children. They had mask mandates in place, and they were very successful in preventing transmission. And this is in the setting of consistent testing of those who are exposed. Again, really low secondary attack rate in the setting of the mask on mask environment. The same data from Wisconsin, data from Missouri, data from North Carolina, even from earlier, even when rates were extremely high in North Carolina, people have been extremely successful.
Absolutely, thank you. Dr. Benjamin, I'll come back to you. We've had a number of questions about the Delta variant, which currently is accounting for about 1 in 5 cases in the US. How could the spread of that variant affect the blueprint you've laid out in this research? Is there more risk involved?
Sure. So the Delta variant, initially described as coming from India, will likely be the predominant variant as we enter the fall. The original Alpha variant, which is what folks are kind of used to thinking about, compared to those variants, whether it's Alpha or the variant originally described from the UK, the Delta variant is more transmissible, that's for certain. It may or may not be a little bit more severe in its presentation. That's not really clear at the moment. However, the vaccines, 2 doses of the vaccine, still prevent severe disease from the Delta variant. And the variant, as best we can tell, does not escape masking anymore effectively. There's not evidence of that. So with the option of either masking or vaccinating, the school environment should be a safe environment, and there should not be a need to change any kind of plans. Now, there are states where there currently is not a mask mandate in the school setting, and those states and in those settings, one can anticipate a much higher rate of transmission in the humans close to each other environment, whether that's summer camp or schools or church, what have you.
Sure, absolutely. That makes sense. Thank you. Dr. Zimmerman, coming back to you, we've had a clarifying question where you mentioned about how the benefit from quarantine didn't seem to any greater than nil. But the clarifying question asks, if students wear masks and they are around a COVID positive person in school, do they still need to quarantine? Is quarantine necessary if schools have a mask policy?
Not in the mask on mask setting within the school building. And there have been several states that have adopted these policies. So mask on mask, COVID positive person who's masking, contact who is masking. In that setting, we have demonstrated very low secondary transmission, less than 1%. Because of that, their schools have demonstrated across the country in places like Ohio, for example, Utah, St. Louis. They have done this modified quarantine policy and have been able to demonstrate that there is not increased risk of transmission either between those people or increased risk of transmission within the community. So the answer to that question is that there should not, or this does not seem to be a benefit from quarantine in the mask on mask environment within schools.
Sure, absolutely. Thank you. That makes sense. We've had some questions coming in regarding vaccines. So Dr. Benjamin, I'd like to come back to you. The first question here asks, do children who are 12 and older who are fully vaccinated still need to wear masks in school, or is it safe for them to go maskless?
So we don't have data from in North Carolina as to whether or not in school for K through 12, what happens when children are not masked. In other environments, however, if people have been vaccinated, they are safe indoors. The vaccine brings the transmission down dramatically. For people who get infected, the rate of severe disease is reduced by 90 to 95%. To give some context to this, a vaccinated child or adult who's been fully vaccinated against COVID, it's safer for them indoors than it is for them to be around somebody who has influenza. So the vaccine is extraordinarily effective and makes life extraordinarily safe as it relates to COVID. We, however, as the ABCs, obviously don't have those data because during the period of this study, everyone was masked.
Sure, that makes sense. And bouncing back to you, Dr. Zimmerman, on another quarantine-related questions, would a COVID positive student themselves still need to quarantine if they are asymptomatic? Do we have any data on that?
So the schools that have implemented the modified quarantine, or the states that have implemented modified quarantine, those who are COVID positive themselves should still isolate per public health policy. It's the people in whom they come into contact who remain asymptomatic, who have a very low risk of transmission, who do not need to spend 7 or 10 days at home in order to, and missing in-class instruction.
Sure, thank you. That makes sense. Dr. Benjamin, we have a question that refers back to your opening remarks. You said that the school districts did an outstanding job preventing the spread of COVID-19 under Plan A, but we've had a question that asks how we can say that when the schools didn't have testing. And so we only knew, I guess, about the cases where people tested positive.
Sure, so let me go back to, because I saw another question about vaccine that asked for some clarification. So if someone has been vaccinated, fully vaccinated against COVID-19, are they safe indoors, mask or no mask? The short answer to that is yes. Okay, so as far as testing is concerned, so testing was often done for symptomatic and even for asymptomatic children throughout North Carolina, but it was not mandated as a part of this study. It was not mandated in the state of North Carolina. And thus, for many children, we don't have test results. However, we do have other states where testing was done, and routinely of all children in other school districts, and there the rate of transmission was less than 1% in those school districts. And we do have information, for example, from the state of Utah, where not only were children tested frequently if they were symptomatic or asymptomatic or regularly, they also did genome-wide sequencing. And then where I can tell definitively if I'm in 3rd grade and I'm infected and I'm sitting next to a 3rd grade classmate and they may or may not get infected, they then get infected, I can tell from the genetics of those 2 viruses whether I spread the virus to my classmate. We know from genome sequencing that the secondary attack rate is less than 1%. So whether we use contact tracing, routine testing of symptomatic people, asymptomatic people, genome-wide sequencing, the results over and over and over again are the same from state to state, from country to country, from continent to continent. If you want to prevent COVID-19, vaccines, extraordinarily effective. Masking, extraordinarily effective.
Absolutely, thank you. Dr. Zimmerman, I'd like to come back to you. Given what Dr. Benjamin's just told us, the blueprint in your report lays out some very specific things that school systems can do, measures they can take on a daily basis. Could you lay out some of those for us?
Sure. So some of the things they should be doing, let's take the masked or the unmasked environment. One would be to make sure that you have good hand hygiene. Make sure people are washing their hands. That's just a standard practice for infection control. Have a sick-free in-person environment. So have a culture where people who are sick should stay home. There are lots of things that we probably need to do to make sure parents can do that and schools can do that. But we have had a culture of kids who are sick staying home, and that's been very successful. In the setting of an unmasked environment, thinking about things like certainly ventilation, thinking about other things such as even testing. These are things that may become increasingly important if masking is not there, and distancing if masking is not present. Those are a couple of things that people can do kind of across the board and should be thinking about across the board.
Absolutely, thank you. Dr. Benjamin, to come back to you, we've had a clarifying question. If you could just talk a little bit about the secondary attack rate, what that means and why it's important. I think you're muted at the moment.
Thank you. The air conditioning was on, so it was a little distracting. I didn't want to take away from what KZ was talking about. In the setting where I come into school and I am seen to have an infection, and I'm the first person with the infection, that's defined as community-acquired COVID infection. Via a combination of contact tracing, I can then look across everyone else at school I'm come into close contact with. Those close contacts are then at risk of getting COVID-19 as defined by the CDC. If those children or adults then develop infection as a result of sitting next to me in algebra class, then that is a secondary infection or a within school transmission. If I expose over 100 people while I'm at school, but only one of them or none of them gets a COVID-19 infection themselves after that, then my estimated secondary attack rate is less than 1%.
Absolutely. Thank you for that detailed explanation. And I'll stay with you, Dr. Benjamin, for a moment, because you talked about the Delta variant earlier. We've had a follow-up question that takes a slightly different angle. It wonders if you can talk a bit about how, if at all, school leaders should think about variants in terms of as they make mitigation plans and as maybe the spread of different variants changes. Is that something they should be factoring in?
So if the children are either widespread vaccination or widespread masking, then I would not make any substantive changes to plans for school. Children should be in person, face to face. We're successful as a state doing this. If I'm in a situation, whether I'm in North Carolina or Alaska or Texas, where I'm in a school setting where the majority of the humans in the building are not vaccinated and not masked, then I can anticipate with the Delta variant a pretty substantial increase in transmission. And the types of things that I need to do are the sorts of things that KZ mentioned, which is to focus on ventilation, to focus on testing, to have people outside as much as possible, to look at some of the other mitigation strategies that in the vaccinated or mask on mask environment are not necessary.
Sure, that makes sense. Thank you. Dr. Zimmerman, we've had a question. Obviously, all of the data you got was anonymized, I'm sure, but the question asks, out of the cases that were reported in the study, were most of them asymptomatic, and were any serious or deadly? Did you have that information?
We did not have that information gathering from this particular study. Danny, I don't know if you would like to speak on that a little bit more.
Sure. So consistently over the year, KZ and I have taken call from the superintendents live in real time as they've had these infections come into their schools. And the experience that we're getting from talking with them, and for the ABC 11, for example, those were the 11 school districts that initially opened up and provided the foundational data from the fall and winter that were the nidus really of successful reopening. From talking to those folks and to other superintendents over the course of the year, it's consistent with data that's reported in the peer review literature. Asymptomatic is about 30 to 50%. Mortality in the 5 to 17-year-old bracket is extremely low with COVID. We're talking on the order of 2 per 100,000. So for an individual child, mortality following COVID is extremely low. 2 per 100,000 doesn't seem like much until you take into account that there are 1.5 million 5 to 17-year-olds in K through 12 education in the state. So now we're starting to talk about non-trivial numbers. As far as, and we did not see death as a result of within school transmission of COVID. And in fact, in the mask on mask environment or the vaccinated students, the risk of being of death from acquiring COVID and dying from it in North Carolina this past year was less than the risk of riding to school in your parents' automobile. So we can effectively prevent morbidity and mortality from this disease, full stop. We have that capability. The morbidity is not zero in children. Recently published from Norway, about 10% of children under 15 will have some types of symptoms beyond 6 months after infection. Some of those symptoms are very soft findings, but other symptoms are impactful.
Sure, that makes sense. Thank you very much. Another question we've had come in, Dr. Zimmerman, I'll ask you about this. Do you have, is there any data that suggests anything about transmission when students share school supplies? Do we have any sense that that can cause anything?
So there have been three situations that have been reported in the literature where COVID has been transmitted via what we call fomites. So pens, pencils, elevator buttons, etc. None of that stuff has actually happened within the setting of the school environment. In the setting of masking, in the setting of hand washing, the risk of transmission from those types of elements is extremely, extremely low. And one of the motivating factors for not having to do things like clean outside equipment anymore within the Strong Schools toolkit, and allowing people to even to play more aggressively kind of together in that setting. So the risk of transmission from objects is extremely, extremely low.
And Greg, if I could just add on to this, because whenever KZ answers this question first, I'm usually chiming in, and whenever I answer this question first, KZ invariably chimes in, because we each forget to mention the following. In the very special needs, high needs environment, in some school districts, it's called the adapted curriculum. In other school districts, it's called the regional curriculum. Children with severe neurocognitive, neurodevelopmental challenges. It's a little bit different with respect to fomite transmission or inanimate object transmission, and cleaning procedures is a much more nuanced discussion for those children and those teachers and for those teaching assistants. We can effectively prevent a lot of the transmission there, but it is a much, much more nuanced discussion.
Sure, that makes sense.
And much different risks for those children who often cannot wear masks than for children in the mainstream curriculum.
Absolutely. Thanks to you both. We've had a crystal ball question, which I'm going to try and frame in a scientific way, Dr. Benjamin, and we'll stay with you. People want to know how soon it's possible that we may not need masks in the classroom. So I guess what I would ask you is, what would we need to see in terms of numbers, or what would the circumstances need to be before masking would be maybe no longer needed in classrooms? Or is it something that we should just anticipate living with?
Well, with vaccination, we're done. So that's the easiest.
Sure.
For the unvaccinated folks, which is obviously not possible at the moment for approximately half the school population, the community transmission, if it drops below 10 cases per 100,000 population per 7 days, and with the Alpha variant in the United Kingdom, there were school districts there that, or schools there that were able to go without masking. It's unclear right now with the Delta variant and its greater transmissibility, what that holds for the future. So the short answer to that is for the transmission rate, we just don't know right now with the Delta variant coming in. As far as whatever policy there should be about masking, that's something obviously that I don't have an opinion on because that's not my role. So I can't really say who should or should not be making any of those types of decisions. All I can say is the transmission with the Delta variant is likely to be substantially higher than with the Alpha variant.
Sure, absolutely. And you've addressed the fact that we're not here to talk about policy, we're here to talk about science. So I will come back to you, Dr. Zimmerman. Obviously, there is all this talk swirling of mask mandates, whether they're needed or not. So I'd just like to give you a chance to kind of reiterate what your findings say about the effectiveness of masking in preventing transmission within schools.
Right. We know that if our goal is to reduce transmission of COVID-19 in schools, there are two effective ways to do that. One, vaccination. Two, masking. In the setting of schools, again, we're not here to debate policy, but the science suggests that masking can be extremely effective in particularly for those who can't get vaccinated while COVID-19 is still circulating. When thinking about whether or not masking is in place, there will be things like anxiety, et cetera, that people will need to deal with moving forward.
Absolutely, thank you. And Dr. Benjamin, I'd like to come back to your discussion earlier about vaccines. Once everybody's vaccinated, then it's done. Obviously, as you say, we're not there right now. And, it still seems to be an open question as to what the final vaccination rate will be if it's less than 100%. Is there a percentage figure at which the risk is virtually nil, or do we just have to keep pushing and look for full vaccination before we can feel comfortable that we're sufficiently vaccinated as a population?
Yeah, most of the numbers that have been thrown out have had some speculation to them, considerable speculation. There's some data that once a community achieves, 40 or 50% vaccination, then the curve of infection changes. That was seen in Israel, but obviously it doesn't eradicate all COVID in that situation, as Israel's now experiencing. We may, we simply just don't know whether it's what the number is and what the intersection or the interplay is between the number of people who have been infected and the number of people who have been vaccinated. And other physicians and scientists have gotten a little bit too far ahead of the data to speculate on what that number might be. To keep perspective in mind, measles is much different than, say, influenza as it relates to how many folks have to be vaccinated. And this is a virus where we simply don't have the experience that we've had with other vaccine preventable diseases to give folks a precise and well quantified and well researched answer.
Absolutely, thank you. Appreciate everybody sending in the questions. We'll be wrapping up shortly, but we have a few questions before then. Dr. Zimmerman, I'd like to come back to you. Some people are wondering about the future of the ABC Science Collaborative with regards to COVID. Are you guys going to be continuing to study this over the coming year? Will you have the opportunity to compare schools that are masking and are not masking to see kind of what differences you make, or what does the future hold for this research?
That's a great question. Certainly, we are willing to continue our research and to continue to monitor transmission within schools in changing environments, as you note, whether that be hopefully increasing vaccination rates, or mask mandates that may kind of fall by the wayside. We do have collaborators across the country, and we'll continue to collaborate with them in pulling data, not only from North Carolina, but also from more than 10 other states in order to make statements about where we are and where we should be going. This is not the last pandemic we'll see, so our hope is that the ABC Science Collaborative can certainly help contribute not only to today, but to information for tomorrow, so that we can certainly continue to protect children, continue to keep them in schools, and come up with ways that will make sure that our communities are safe.
Absolutely, thank you. Before we wrap up, we've got a couple of questions to talk about the difference between younger children and older children. Obviously, vaccination is one of those. And Dr. Benjamin, I wanted to ask you, even though it's beyond the parameters of this briefing, what's the latest as you understand it on the time frame for which we might see children under 12 having a vaccine available to them?
So the tricky item for children under 12 is that a different dose is needed for children under 12 for the leading vaccine candidates. That is, as Pfizer comes through, Pfizer's first through the queue. For 12 to 15-year-olds, we were able to use the same dosage as for adults. For under 12, it's a little more complicated and a little more longer of a study, and a little less certain as to when we might have those results. We speculate that those results will likely get submitted to the FDA in late 2021, and thus an authorization could occur after that. And then, of course, all North Carolina school children would be eligible for vaccination. I did see two other questions in the chat, and that is, could younger children, do they have a difference in their ability to wear masks differently from older children? There have been several school districts that have formally studied this. We've partnered with a couple of different school districts on this, and we will have those data available this summer. But it looks like the compliance rate is extremely high and is not predicted by age. And that's when school leaders and school teachers go through and assess random selection of people in the building as to whether or not they're wearing masks, and if they're wearing masks appropriately over nose, mouth, and chin. And I will say, regardless of, I've seen several questions in the chat around, do we recommend or not recommend certain policies or mandates as a result of that? And again, it's our privilege as a research group to partner with the state of North Carolina. And it's ultimately the policymakers of the state that make those decisions. They've got a lot of other things to consider other than just the findings that we have in order to make the decisions that they need to make. And legislators from both sides of the aisle, in the House and the Senate, the governor's office, DHHS, DPI, this is a state that has done an outstanding job with K through 12 education as far as it relates to COVID-19. And to my eye, we've done it better than any other state in the country. And our policymakers to date have done a phenomenal job in the toolkit and in the legislation that they put together that was bipartisan. And thus far, this has been a group of folks that have really represented us really well with respect to transmission of COVID-19 in schools. And, from personally, I'm very grateful to have worked with our policymakers over the past few months.
Thank you, Dr. Benjamin. Dr. Zimmerman, I gather you might have something to add on the differences with masking in children under 12. What can you tell us about that?
Sure. I just want to go back to something that Danny said previously about how children are really, they can be influenced and they're moldable and they follow the lead of adults. We have districts here in North Carolina that have done a really amazing job. They've even made masking a fun thing to do. They've had, masks that children like and been able to get those to children, but also done things like creating raps or songs to encourage masking. And so have really done this in a way that's encouraged this to be something that's part of their everyday life in school. And children have just been very happy to be there and so have complied by all of the rules. I think the districts have done an outstanding job in supporting students in this endeavor. So there are certainly ways to do it, whether you're young or whether you're old. People have done a really good job.
So just to add on to that, Greg, in addition to the policymakers that have done an outstanding job, the superintendents and the other school leaders in this state have simply been amazing. And we were able to partner with them, obviously the ABC 11, but really across the state. We have a very strong group of superintendents, and the teachers and school principals with whom we've worked, and we've had hundreds of teacher meetings and principals meetings over the past year. That's really where this enforcement of the masking within school, that really happens. And that's a sacred trust that those individuals have done to protect themselves and each other and the children involved. It's yet one more task that our school staff and our school teachers have taken on. Some of those folks, we had NCAE reach out to us at the beginning of the school year on ways that they could help. We had individual teachers reach out to us throughout the year on how they could help, and obviously school administrators. And that dedication across the board to really ensure the adherence to masking, all of this would have fallen apart if the folks who are in the building, if they had dropped the ball, all of this would have fallen apart over the past, certainly the past 12 months while we were full-time face-to-face. So really, really well done by the K through 12 education system.
Gotcha. Thank you very much for that. We are about to wrap up here, but before we do, I wanted to ask you both, since you are both parents, but parents of children of different ages, for your perspective on this. And Dr. Benjamin, I'll start with you. Would you feel comfortable sending your children to in-person schooling in the coming year if there were no masking in place?
Well, for me, it's easy because my 4 children are old enough to be vaccinated. My oldest goes to Western Carolina, and he's a member of the rescue squad for Jackson County, and he's been vaccinated, and he does his job for the rescue squad and goes to school, and he's doing great, no problem. My second son is in military school. They're going to resume. He's on military scholarship, and ultimately will be headed into the Marine Corps. I'm fully confident in him going back for some very intense personal instruction that I'm sure he's going to receive when he goes back to school. My younger 2 sons are in high school, and they've been vaccinated. My sons were involved in the Pfizer trials. I was in one of the follow-up studies. My wife was randomized in one of the vaccine trials, so very comfortable with the vaccination option that the old folks older than 12 have, whether or not there's masking.
Sure, thank you. Dr. Zimmerman, you have a different situation. You have a younger child or children, so how are you thinking about sending a child back to school if there were no masking?
This is much more difficult for me and my son in particular, who is under the age of 12 and cannot be vaccinated. Certainly he will be wearing a mask, but unfortunately masking and its protection and maximum effectiveness doesn't work like that. My mask protects you and your mask protects me. So for this to be maximally effective, particularly in those under the age of 12, and to reduce the risk of COVID, it's best if there's masking in place for both people, if our goal is to reduce the risk of COVID. So it is a much more difficult decision for me.
Absolutely. Thank you very much. I think that's the perfect place at which to leave this. Thank you everyone for joining us. Thanks to our panelists, Dr. Danny Benjamin and Dr. Kanecia Zimmerman, for sharing this research with us. If you'd like to be notified of upcoming briefings, then please do email us at dukenews@duke.edu, or if you're watching on YouTube, just like and subscribe. In the meantime, please stay well. And remember, as Dr. Zimmerman just pointed out, masking is not just about you or me, it's about us and all of us, and we all need to do it in order for it to work. Thank you very much, everyone.